Thank you for joining us today, this kickoff of, and I am very excited to welcome you today. But the true star of the show is going to kick off our meeting here. I gave you directly from his hospital bed, Jerry Walter.
Okay, I'm unmuted. Welcome, everyone. I wasn't going to start off being emotional, but I'll just take a second. So I'm here today from, let me show you my my little pillow, if I can get it lined up. There we go. From the Duke Heart Center. And so as we were planning and organizing the conference, I got called on the list to get a heart transplant. So on Tuesday of this last week, just a few days ago, that's what I did. So I'm sitting here just a few days after the transplant. I received a great heart to fit my body, and I'm doing great. I'm recovering well, and I'm able to be here with you for a bit. So to make this happen, and I know Dawn has a slide in a few minutes, to make this happen with the help of our contractor, Technology and Innovation and Education, TIE, and with much help from Dawn Laney, which I'll talk about more in a second, we've actually pulled this off in the process of getting a heart transplant. And of course, my wife, who's always at my side and has gotten me through every step of this successfully, to where my life will be different after this week. Get out of here and start the new me. So if we can go to the slides, Dawn, that would be great. Oh, so I guess this is this first. Can you go back one more? Is it Brenda or Megan? Yeah. So first thing I want to do is just welcome everyone. As you know, this conference is our 10th annual conference, and they've all been on site along with Victory Junction in the past, except for the first one where we only had the conference and not camp. And so, but our primary attendees for this event are the individuals with Fabry disease, their family members and caregivers. But we also wanted to invite all of our other people that are usually at the conference, our industry folks, clinic folks who wanted to attend, and other companies. So everyone's here, and we're so happy to see everyone and have everyone participate. And thank you for being with us. Next slide, please. So I just want to share with you all of our sponsors that help bring this all together. So you can see the list of companies that are vested in Fabry disease, have treatments available, have treatments pending, or in clinical trials. And just we want to say thank you to all of you who not only support us with the conference and camp every year, but with other programs. And we want to thank all of our individuals that donate throughout the year that help us provide all the programs that we provide. So we're really thankful for all of that. Next slide, please. And thank you to all of our, we have a great cast of speakers. So thank you to our all of our speakers who generate or who donate their time and efforts and are providing different education talks on various things, and our industry speakers and our clinic speakers. And so we really thank all those people for doing what you do for us. And I'd like to make one more comment. I think, well, go ahead for next slide, please. So I just mentioned Dawn. She's much more appropriately dressed than I am. I'm in a hospital gown, but we just want to thank Dawn so much for all that she's done in the planning and the preparation and managing, and now more host than co-host. I turned out to be in the co-host role for this because of my situation. So I'll be with you on and off throughout the day, but they'll drag me out for an x-ray or blood or something throughout the day. So I'll be here and there. And just thank you so much. And thank you to the people at TIE, Megan and Brenda and Lindsay and the other folks that contribute for putting all this together and I just hope we all have a great conference, and I look forward to popping in throughout the day. Dawn, it's all yours.
Thanks, Jerry. That was wonderful. And we're so excited that you're here and be able to talk with us and kicking off our meeting. It makes it extra special today.
Sorry I cried.
Oh, I am the last person to shame you for crying during events. I always cry too. All right, so I just want to do a little bit of logistics for us. This is really going to be an exciting day. We're going to hear from lots of experts. It's going to be a long day, so I don't want you to feel guilty if you got to turn off your camera for a moment and head out and do some bio break or get some food. But you won't want to miss a minute, so keep an eye on what's coming up and make sure that you have everything set up for you. There, you may have noticed down at the bottom of the screen, there's like a little bubble that says chat. And a lot of times it's going to have a number beside it or something like that. That chat box is your great friend today. And we're going to do a little experiment because with each speaker, you have the opportunity to be put in a drawing to win an Amazon gift card, which is really cool, but you've got to know the magic secret code. So during a talk, maybe at the beginning, maybe the middle, maybe at the end, for every single one of our speakers, they're going to tell you the secret code. You're going to put that, your name, full name, first and last name, and the secret code in the box. And then at the breaks, we will draw for each session out. Now, if you don't put your name and your secret code in the chat box, we're not going to be able to pull you out of the drawing. So make sure you do that. That's, yes, a sneaky way of making sure you're paying attention. However, also fabulous prizes. Come on, this is a great thing. The other thing I want you to know is that there is the team chat session going on today from 2 to 4, which will be in a separate session from us. And I want to thank the people who are facilitating that meeting. That's Dr. Rob Hopkin. That would be Gwen Gunn, who's one of our wonderful genetic counselors here at Emory. And then also Stacy Fior, who is just an amazing, amazing health psychologist who's facilitated our group before and just does an amazing job with our teens. So if you have a teen who's not signed up, just email me or Susan and we will get them signed up and in the meeting right now. But I'm hoping that we have a great day, and I know that the teens are going to have a great session. So all together. If you have, go ahead.
So let me just make one more comment that I forgot to make. So the things that Dawn just talked about, the interaction with the attendees, just remember that the interaction with the attendees, the polling questions, the prize drawing questions are reserved for the primary attendees, the adults with Fabry, family members and caregivers, and our other attendees who were really appreciative that you're here. You can't play with that. So,
that's right. We're tossing your name if it comes up. So that is about it for me. I believe Rob Hopkin is our first speaker. I want to make sure that he's on before I cue him up to speak.
I am not seeing him in here yet. If you are in here, Rob, if you could raise your hand.
I'm watching. It's early for him, so he theoretically would be on at 11:30. But if we're ready, and he's not quite here yet, then what I can do is I can go ahead and do my talk because it's quick. And I know that's going to make you all go, what? Your talk is not till later. Well, it's okay. I can do it now. And the more ahead we are as we go through this meeting, the better, right? Okay, so I'm going to go ahead and share my screen and we'll jump straight into my talk, which is Fabry and COVID. But first I must bring it up because I wasn't quite ready for that yet. Just to let you guys know, when it comes to answering questions, the easiest way to ask questions for the speakers is to put it in the chat. And our wonderful folks from TIE, Brenda and Megan, are going to go through those particular questions and they'll pull them out to ask for us as we go.
Dawn?
Yeah?
If you would, because we got through, sorry, because we got through the introduction part so quickly, if you'd like to pause for a minute Before starting your talk, I've got another topic I can talk about for a second.
Absolutely. Go for it.
So what we've been doing for a very long time is trying to educate the community more about classic and non-classic mutations. And I know Dr. Hopkin is going to talk to you about that more formally, but I just wanted to tell you some of the initiatives we've been doing. Is we have a mutation repository, and as we do our surveys and as we talk with people and interact, we've been trying to put people's mutations in the repository. And then when we do our surveys, and we ask people what their mutations are, it makes those surveys much more meaningful, because you can we ask a lot of questions about symptoms. So we can, if we know the person's mutation, what that is. If we ask a person's mutation, and then we look at their symptoms, we can help provide insights to what happens between people that are classic and non-classic, also called later onset. We can provide insights to researchers and physicians to further discover, provide some definition about what that really means. So what are you what's expected to happen if you have a non-classic / later onset mutation versus what's going to happen if you have a classic mutation? We all know that it varies among individuals in all of those groups, but we hope to help provide some definition to that. So when we ask you to do the surveys and you contribute to those, the more surveys that we get, the better that we're able to help and provide a more full story. And so I encourage you, if you don't know your mutation yet, to please ask the physician that tested you. If a lot of people got it done at Mount Sinai, we can go to them. You can contact us for some assistance and some help. We already have a complete list of people from the last survey that asked for help that we'll be responding to soon, in either finding their mutation or clarifying what it means in terms of all the various, and if you look in our NFDF Fabry Community Landscape document that's on our website, pages 15 through 18, you'll find more of a layman's description of mutations that you can read and kind of help everyone better understand that. So please help with that as you get opportunities to do the surveys, find your mutation, and then the answers will make a lot more sense to us in terms of what's going on with people. That's my 2 cents. I still didn't take up much more time, but that was something that I was hoping to get on the agenda.
Jerry, there is a question in the chat from Eve. Is there a way to find out if others have the same mutation or if our family is the only one?
Well, we can't share mutations at all. We can't share who has what mutation, but if a person, for instance, looking for someone, we could say, if you tell me I've got A143T mutation, very common, lots of discussion about it, and I'd like to contact other families. We could ask other families if they want to be contacted, and then when you both agree, we could share that with each of you. We can't outright share anything. We won't share anything without permission from both sides before we did it. Is that kind of what you mean?
Yep, I think that makes a lot of sense. I would also add that right now there are 3 free testing programs that you can use to get your mutation tested if you don't know what your mutation is already. Your doctor can hook you up with whichever one makes the most sense for you. There's one that's through PerkinElmer called the Lantern Project, that's for all LSDs. There's one through Invitae that's called the Sponsored Lysosomal Testing Project, I believe. I can't remember what it's got another cute name, but I can't remember what it is right now. And then there's one through the American Association of Kidney Patients. And any of those programs can look through your genes and try to figure out what could be causing Fabry disease in your family. So good point, Jerry, that's a good one. And those are things that can be very helpful as we learn about new therapies and as things move along. So it's good to know your family mutation. So I have received notification that Rob is on the call. So I am very honored to introduce you, a man that really needs no introduction in the Fabry community. Dr. Rob Hopkin is an associate professor of clinical pediatrics at Cincinnati Children's Hospital Medical Center. As you know, he has been a go-to person as an expert in Fabry disease in the community for many, many years. And he also does a really good handstand, particularly as he crosses home plate during kickball. So with no further ado, I give you Dr. Rob Hopkin with his lecture on Fabry disease updates, which is actually always a highlight for me as well as you guys. All right, let's see, we've got working on unmuting and sharing. Let's see what we can do here.
Yeah, just, well, Dr. Hopkins working on it.
Yeah.
This is new to all of us, this whole virtual conference thing. So it's a huge experiment in planning and pulling it off. And so I'm sure we'll have a few technical difficulties, and this isn't even a technical difficulty. We've called them on a few minutes early. This is exciting and new and scary all at the same time.
All right, I wonder if, I don't think he can unmute himself.
A minute.
Oh, I heard something.
Now I should be.
Gotcha, I can hear you loud.
Okay. This has not gone as smoothly as I'd hoped it would, but we had done most of the stuff correctly. On the other hand, the link that I had only worked for the teen session this afternoon, so panic mode hit at that time. Okay, let me go to share screen. Okay. Okay, now I should be ready to go. So we're going to be talking about Fabry disease. That should not surprise anyone. This is my disclosures. Basically, I will talk to anyone who will talk to me about Fabry disease. I do not own any stock in any of the companies. And nothing I say in this talk has been influenced by any of the companies other than just what my personal experience is. And we're not going to be talking about most of the direct products anyway. So what we are going to try to do is go through an overview of just Fabry disease in general and looking for sort of what are the things that we need to pay the most attention to, and then talk about some new things. Now, this is meant to be helpful information for people in the audience who either have Fabry disease or have family members with Fabry disease. And what I hope is that people will have some questions, that we'll have some time for discussion. And what I would ask at this point is to have you use the Zoom program chat function and submit questions, and have Dawn read those, and then she can interrupt me or read them at the end, and we can discuss the questions as they come in. That way, because with my screen the way it is right now, I won't be able to see the questions, but we will be able to, you can ask your questions at the time that they come to you, not try to remember them. So to begin with, as I think probably most of you know, Fabry disease is a deficiency of an enzyme called alpha-galactosidase A. And that breaks down a molecule that I'll show you a picture of in a minute that is called GL3, but that's actually a family of molecules. There are at least 15 different varieties of GL3. And we are not going to go into the chemistry at all because I don't want to know it, and I'm sure that most of you don't either. Buildup of those molecules in the cells eventually leads to cell dysfunction, and as that progresses, it leads to death of some of the cells, and they are replaced by fibrous tissue, which is basically scar tissue. And eventually, as that continues, it leads to organ damage, which leads to organ dysfunction, which leads to early death if we don't do anything about it. Now, when I started dealing with Fabry disease in the late 90s, that was the way it was. And we could do things to treat the symptoms, but we couldn't really address the natural history of the disease. Fortunately, we are in a new world now. So this is a picture of podocytes, and the one on the left is Fabry disease. You will note all of the little inclusions that are black within the cells, and those represent the storage, and that's taking up a lot of the picture. Now, I don't know if I'm pretty sure that actually that the picture on the right is closer up, and it would be, you guys see my cursor? Okay, if you look at that line, that would be the same as this line. Okay. Now on here, you see all of this storage. Equivalent to that is this space out here. What you see is that it's not full of anything. These little things are these little bumps on this inside. This is what it's supposed to look like when it's healthy. This is what it looks like in storage of Fabry disease. And not every cell is that dramatic in difference, but you can see that there's a big difference between the cells. And as that storage progresses, it does multiple things. One of them is just distend the cells so that the cells shape and therefore function are not normal. But it also causes the cells to feel stressed, in which case they send out signals to surrounding cells that change the biology around them. And that combination of those things, we don't know all the details, but the combination of those two different responses to the storage are what lead to this disease. Now, I mentioned that GL3 is a family of molecules. This slide has two of them. One that is most common and we just refer to as GL3. The name of it is right here. If you want to try to pronounce it, go for it. I'm not going to. And this right here is an attachment. R is a variable thing and can be of various sizes and shapes. This lower one is lyso-GL3, and it is missing the R over here. Has it R and the oxygen here are replaced by a hydrogen. Now that's a small difference. Doesn't look like much, but it makes a big difference in what the molecules do. So GL3 is the most abundant stored material, but the amount of GL3 you have doesn't correlate very well with disease progression. It hasn't been demonstrated to have direct tissue toxicity. It drops quickly to normal levels in the plasma once you start treatment, and the levels measured in the plasma do not correlate with disease severity or stage of disease. If you look at lyso-GL3, it is much less abundant, but if you add lysogl3 in healthy cells, if you put, growing them in a petri dish, and you put GL3 into the fluid that you're using to provide nutrients to the cells, it causes renal fibrosis. It also causes proliferation of smooth muscles and heart muscles, which contributes to hypertrophic cardiomyopathy. It may, although this one has not been proven yet, induce changes in the nerves because it changes the calcium levels in nerve cells, which is known to be important in regulating when the nerves fire and therefore how sensitive you are to pain, but no correlation between lysogl3 levels and pain levels has been identified to date. Furthermore, lysogl3 levels can be used as predictive for classical versus non-classical disease, and they're variable and to some extent correlate with the speed that the disease is progressing, at least in females. Not a perfect biomarker, but a better biomarker. So when you are getting testing, you want, one, to get GL3, because if your GL3, the just normal GL3, starts to come back up while you're on treatment, there's a problem, and you need to figure out what's going on. Make sure that if you're on ERT, that the ERT is being mixed correctly, that it was stored correctly, that you're getting active enzyme, or that you don't have antibodies or something that are interfering with the effect of the enzyme. Okay, so lysogl3 levels, there's a few things you need to know. I just said it's a better biomarker. It's not a perfect one. Females may have normal lyso levels and still have Fabry disease. Abnormal levels, anything above 1, this slide says 1.3, but I think 1 is also accurate, indicates some degree of Fabry disease, and levels greater than 45 suggest that the phenotype will be classical, and that's pretty reliable in males. It is much less reliable in females. However, measuring the levels and monitoring them in females is still thought to be useful and important. It's just not quite as predictive. So we just gave part of a definition of classical Fabry disease. Enzyme activity measured at less than 5% of the mean for the general population will usually result in multi-organ disease and symptoms, and that has been considered evidence of classical Fabry disease. However, there is some disagreement with, there's a substantial number of people who think that we should only count the people with less than 1% of the average as classical Fabry disease. There is a difference between somebody with 4% and somebody with 0.5% clinically. And the question is, how reliable is that? And the answer is, we don't really know, because there isn't really a distinguishing boundary between classical and non-classical Fabry disease. It's not a type 1, type 2 thing. It's a spectrum. You have some people who make 0 enzyme, some people who make something in between that. If you get above about 35% of the normal, you shouldn't get disease. but there's a whole spectrum of things that can happen in between. And the enzyme level is only one of the things that predicts outcome. So there are other things that can modify the phenotype. So we need more things to do. Look at. So looking for classical Fabry disease, usually you see more than one system involved. For example, men with classical Fabry disease who are over 40 years old usually will have both heart disease and kidney disease. If you look closely, they will also usually have some of the other symptoms like chronic fatigue, pain, lymphedema, GI symptoms. And most, now women with classical Fabry disease can have all of the stuff that men have, but there's a lot more variability, and there's a lot more variability in the age. Some women who have mutations associated with classical Fabry disease will not get sick. Most of them will get sick. Age of onset is pretty variable, and we just have to do the best we can with that. I still think that somebody needs to fund an at least 5-year-long natural history study that includes treated and untreated women in females with Fabry disease that we think would have classical disease, so that we get a really strong understanding of the natural history and what things predict progression versus stability. So non-classical, you may gather because it has a different name, has some differences from classical Fabry disease. The enzyme level is typically between about 3 and 25%. Few people will get symptomatic with between 25 and 35%, and there's debate about where those cutoffs are, and I think they might not be solid numbers. Many people with non-classical Fabry disease will not have pain, angiokeratomas, GI symptoms. Some will, but not everyone. Often only one of the major organ systems in the body will be involved. Usually that's going to be heart disease. Now, if you do tissue level biopsies, you will see storage in more than one organ system. It's just that it doesn't progress to the point that it interferes with the function of the organ in many cases. Onset of symptoms varies from adolescents into people who first are identified in their 70s. I haven't met anybody who became symptomatic after their 70s. I don't know if that exists. It might. Even with that late onset, this is still a potentially life-threatening disease. We still need to pay attention to it, and it's much more likely to be missed than classical Fabry disease because the patients don't have any clues about what's going on. If they don't know the family history, it may be very hard to figure out, why does this patient have heart disease? In some cases, actually, even after you've sequenced the gene, done enzyme measurements, you may actually have to do biopsies and look for storage to really be sure what the diagnosis is. Now, all of that variability leads to the problem that this slide is about. And what you see in this is onset of symptoms. This slide is dealing with classical Fabry disease. Onset of symptoms, And you see that that is the bar in the middle of the blue is less than 10 years of age. And then diagnosis, and sadly this is still pretty accurate, is in 20s and 30s. So it's a long time later. The most recent data that I've been able to find is it's still more than 15 years on average for someone who doesn't have a family history. We need to do better with that. And then if you look at the orange bars, those are the major serious health problems and when they occur, and they are going in about 10 years after the diagnosis, which is close to 30 years after the onset of symptoms. And then people are starting enzyme therapy later. Now, we have improved a little bit on the enzyme therapy. If we were to redo this slide now, that would be a little bit lower, much closer to the age of diagnosis, which is good progress, but it's still not good enough because starting people on treatment in their 30s leaves some irreversible damage and a high risk for some continued progression of the disease that might be preventable. So this slide is a little bit complex, but it's one of my favorite slides on Fabry disease. This is data on men and women and classical and non-classical disease. If you look at the bottom line here, this is men with classical Fabry disease. So if you go over here to before age 30, this is looking at major life-threatening complications. If you go back here before age 20, you see that people don't usually have those. But starting in their 20s, men with classical Fabry disease have a significant incidence of major health problems. And it goes down and currently into their mid-50s. And then we don't see a lot of men at that age if they're untreated with classical. Now, I want you to try to guess what this line is. Oh, it's already on there. Never mind. I should have taken that out. The next line down is women with classical Fabry disease. And what you see is that they still have a high incidence of major things, major health problems. It starts a little bit later. Next line over, this one, is men with non-classical Fabry disease. So the women with classical Fabry disease have earlier onset and more severe progression of Fabry disease than the men with non-classical Fabry disease. That is really important, and a lot of people don't recognize that. And then over here is women with non-classical, and I want you to notice that out here, this is about age 70, 50% of the women with non-classical, which is the milder forms of Fabry disease, still have significant health problems related to Fabry disease. What kinds of problems do they have? So this slide is not entirely accurate because this is kidney disease. This is men with classical Fabry disease. But this is people who were at age 40 when they started treatment, and you could only have one renal event. So these are people who were diagnosed and started on therapy, and then we followed them out. And you can see that a lot of them did have kidney problems, but it's underrepresented because in reality, this should be at least twice as big as it is. But you also see that a lot of people didn't get on treatment, didn't get life-threatening complications. This is females. If you look here, this is not kidney disease. This, in females, so the no events is similar. It's a little bit bigger for females, but this is heart disease, and heart disease is the biggest life-threatening problem in women with Fabry disease, followed, and it doesn't, I didn't get the proportions very well when I made this slide. Stroke should be bigger than kidney. If you look at the numbers. So it's heart, stroke, kidney, other for women, and kidney, heart, then stroke for men. That is important because it tells us that our priorities for what to pay the most attention to are different between men and women, which means the disease process must be a little bit different between men and women. Thus my call for a really good, detailed study of a large population of women, because we don't have one. Okay. I'm not going to go into a lot of detail on this because you will have other speakers talking about the individual findings, but pain is often the first symptom in people with Fabry disease. And I have many patients who have told me that if they have to choose between pain or kidney disease or pain or heart disease, they would want to treat the pain more than the other things. As the disease priorities change, that could certainly change. But the point here is pain is not a mild problem. It's not something most people just want to live with. It's a real issue. It's a significant issue, and we need to pay attention to it. You need to talk to your doctors about it, and it's okay to admit that it hurts. And we need to find good ways of treating pain, and we need to have ways of tracking the different approaches people try and finding out which ones work and which ones work best over time. And we're working on that, but we have a long ways to go. GI symptoms are another very early one. I was a little bit shocked when I saw the numbers of people that have significant GI symptoms. It's the majority of patients. And now, abdominal pain is common in the general population and is one of the symptoms related to Fabry disease, but diarrhea, nausea, and vomiting are not common in the general population and are all very common in people with Fabry disease. Heart disease, 50% of men with Fabry disease will have some progressive heart disease, 35% of women, and these will lead to serious complications. In women, more than 50% will have their first serious, potentially life-threatening complication be a heart-related problem. And overall, in adults, even with the current treatment strategies, 40 to 60% will have evidence of heart disease. It is clearly the leading cause of death in both sexes and something that we need better detailed information on. And you will hear about that in more detail later. Kidney disease is the leading life-threatening complication in men with classical Fabry disease. Women still have greatly elevated kidney disease, but it is not their leading issue. Heart disease is. Stroke. So compared to 60% with cardiovascular disease, 6.9% doesn't seem that high, but it's still 12 times the general population risk for stroke. And look at the ages of those first strokes. Now, I find it surprising to have anybody under age 65 have a stroke. It just doesn't seem right unless there's some other risk factor. Again, something we definitely need to pay attention to and work on treatment. This slide kind of summarizes all of this information we've gone through. What I've been talking about so far has been adults. This gives you the distribution of those same kinds of symptoms in the pediatric population. As you can see in kids, the things they notice are not going to be heart or kidney or stroke. It's going to be pain, GI symptoms, and one that is not on this slide, energy levels, are going to be the biggest things that we hear most about. If I'm wrong, the teenagers can feel free to correct me this afternoon. But the kids do have a significant burden of disease. This is not an adult onset disorder. And we do need to pay attention to it. There's a lot of debate about how aggressively we should intervene in childhood. And my prejudice is if you have symptoms, you should be on therapy. And if we know you are going to be getting symptoms soon, you should be on therapy. And we need to get more sensitive early things that we can monitor so we can start patients at the right time on therapy and minimize damage.
So Rob, there's a question that I think falls really nicely in this point, which is, what if you have a family member who has some symptoms of Fabry disease and refuses to admit they have Fabry disease and need treatment, or to get tested?
Okay. So one, the testing to make sure that they do in fact have Fabry disease is really important. I have had at least 3 patients who came to me with the assumption that they had Fabry disease. They had, all 3 of them, a family history of Fabry disease with a known mutation. One of them came in with kidney failure, hypertrophic cardiomyopathy, and pain. And it's like, I don't even know why we need to do this test. But he didn't have Fabry disease. He had something else. And if we had put him on Fabry disease, we would have taken time out of his life, spent buckets of money, and it wouldn't have benefited him at all. So we do need to make sure that we document actual disease in all patients, because there are other conditions that can overlap. We also need to make sure that, people do have a right. I have patients in my practice who know they have Fabry disease, some of them with serious health problems related to Fabry disease, who refuse treatment. I don't like it, but they have the right to make that choice. Pediatric patients, it's a little bit different. Their opinion does matter, but it might not be the final say. Usually that's the parents. So how should we approach that? The main things that we need to do is make sure that people understand that Fabry disease is a real health problem, that there are treatments, that the treatments actually do improve longevity and quality of life, and that they are effective. They change the natural course of the disease. Now, are they going to cure you? Not yet. We're working on that. But will they help? Yes. And they have helped, and I think we are extending people's lives substantially at this point. We need to run some new analyses and update that, but the evidence that I've seen indicates that we are, in fact, prolonging life and changing the natural course of this disorder.
Yeah. And Rob, we had one comment just to let you know that there are definitely females who are in their 70s with Fabry disease. And then someone else asked, what is the age of the oldest living Fabry patients, male and female?
So oldest living, I do not know because I don't have a way of tracking that. I'd need worldwide data. I have seen patients with Fabry disease who were in their 80s. That was late onset Fabry disease, not classical. But I have at least one male patient who started in clinical trials prior to any treatments being approved, who is now in his 70s with classical Fabry disease. So we can get people pretty far into life. And I have had patients, I don't know if I have anybody in beyond their mid-70s right now in my practice. I do have a couple of men in their 70s and a couple of women in their 70s. I don't know if I have anybody who's 80 yet. I have had, but one of my octogenarians passed a year or so ago. But when you think about what the expectations were in the pre-treatment era, men with Fabry disease in their 70s was almost unheard of. And now we have classical Fabry disease living into 60s and 70s.
Yeah. And I think we've got a great example of that here on our call. Jerry Walter.
We do.
We do.
One of my favorite people.
Exactly. There's a couple other questions that are focused on antibodies and ERT. Someone asked, how do you know if you have antibodies that interfere with ERT? And then what do you do if you have antibodies to ERT? Which I think might fit later with some of your new stuff, but I wanted to let you know those questions are out there.
Okay. So I will just answer that now. To find out so most men and a substantial number of women will have some antibodies if they're on ERT. And that is important, but most of the antibodies do not interfere with the function of the ERT, at least if you're at a high dose. The way that you would know that, so there's two answers to that. One is if your GL3 or lyso-GL3 start going up after you've been established on therapy for a while, that's an indication that there's something going on and that you should consider antibodies that are interfering with your therapy. But the bottom line is the only way you can really find that out is by having your doctor request an inhibitory assay on the antibodies that you make. It's a blood test, and it's available, but it has to be specifically requested. If you do have that, is there something you can do about it? The answer is yes. If you have a high dose of enzyme, that can help because it can deliver enough enzyme intact. But if you're having a lot of infusion reactions, having a higher dose of enzyme can increase that. So we need other ways to deal with it. There is a case report by a guy named Bernstein within the last few months that talks about a patient who happens to be in my practice. My name is not on the paper because I didn't respond quickly enough when they asked me questions. But that patient had very severe antibodies that were clearly interfering with it, and we had to find a new way of treating him, and got an expert in drug allergies involved, and were able to get him on treatment, maintain his treatment response at the levels that it had been before that problem developed. So there are things to do about it. It's a difficult problem, and it's one of the hot topics that's being worked on in Fabry disease right now.
There's a follow-up question. How do you, if you don't have symptoms and you have neutralizing antibodies, what do you do?
If you don't have symptoms and you have neutralizing antibodies and your treatment response using these standard measures that we have is stable, meaning your GL3, lyso-GL3, urinary GL3, kidney function, heart function, and heart muscle thickness are stable, you keep monitoring your levels and you continue your treatment. At least that's what I would do. If, on the other hand, any of those things are heading in a direction we don't like, then we need to look at ways of trying to change those the antibody production, or change the treatment regimen that you're on to account for and ensure adequate response to treatment. And I can't tell you exactly what that's going to be. We are actively working on that. There have been a couple of recent publications on it that I will talk a little bit about, and there's meetings planned to talk about this. But I don't think there's I don't think there's going to be a one-size-fits-all answer. And two, we haven't reviewed what people are doing closely enough to know even what all the options are at this point.
We do have another question, which is, how do you know if your mutation is classical or late onset if you've been told both by different doctors?
So we do have some mutations that are not completely classified. And so I would look up the definitions and pick, are you going to use 5% or less than 1% as your cutoff for lyso? That's up to you, but you look at the symptoms that you have, and there are some published guidelines for those. And it's a combination of symptoms and tests. So I would say if you had onset of symptoms before age 15, if you have multiple system involvement, and if you have lyso levels untreated above 45, that's a classical phenotype. Regardless of your mutation, it's a classical phenotype. And there are a few people who have what are typically late onset mutations, but for some reason present with a classical phenotype. So the N215S mutation is one that is specifically noted to have that happen occasionally. It's usually late onset, but there are patients that are well documented who have earlier onset. We don't know all of the reasons for that. It could be genes that are not related to alpha-galactosidase A. It could be other things. So for example, I have had 2 patients with late onset mutations who came in with symptoms at an earlier than anticipated age. Both of them, when we dug into their medical history, had had previous events that placed their heart and kidneys at risk. And some of their body's resilience had been damaged by those previous medical events. So you can have other things that modify your specific course. And that's okay. We need to deal with it, that this is a sliding scale, not a box that you go into one or the other.
I think this is a great opportunity to say to everybody listening that Rob's secret code word that you need to put in the chat box and put your name with it for the drawing is handstand. So if you're listening right now and would like to be in the drawing, put in your first and last name and handstand secret code.
Okay.
Good job, guys.
Now,
I see it now.
Now do you want to hear about some new stuff that's just coming out? Okay. So this one, the name of this is kind of complicated. You can read the title of the paper up there. But this I thought was really kind of exciting. It's a new way of extracting and purifying enzyme out that's been produced in, the method of production wouldn't change, but the way they pull it out and purify it would change. And it is more efficient, faster, and costs less than the current mechanisms. So we would be able to produce higher quality product at lower cost and in greater quantity if this works. So I do not know what it would take to convince the companies that make enzyme for Fabry disease to look into this. I do not know what the FDA requirements would be, if this would be a change that would reclassify the drug as a new drug and require new clinical trials or what. I think it's cool that we're getting better at this stuff, and that should help us to have a more reliable supply chain. So still new science being done, even in areas where we think we've got it down, and new advances being made. This one I thought was really interesting because we did, on the Fabry registry, we did a study looking at time to effect when we start treating people with Fabry disease. And our hypothesis was that when you start on treatment for your Fabry disease, it's going to take a little bit of time, or a lot of time, depending on which cell type you're looking at, to clear the stored material. And then it's going to take a little bit of time for the cells, as they get more healthy, to reestablish function. And what we found was, for the life-threatening events, it takes at least 6 to 12 months to start seeing an important change in those. And so my assumption has been that it just takes that long for the drug to start helping you. And then I found this, This is a brand new article, and there's details in it that I still am trying to wrap my head around. But starting with the first infusion, they monitored blood pressure in patients, and they followed them out for at least a year. And what they found was with the first infusion, the day you get that, you see some benefits to your health with Fabry disease, with improved vascular stability and improved blood pressure stability, and partial normalization if you had higher blood pressure in the first place. This has a couple of implications. One is that earlier initiation of therapy is even more important, knowing that we start to see benefits that much sooner, and that there are effects that are not directly related to the to clearing the storage load. And two, that there are still mechanisms of Fabry disease that we don't completely understand, because this is not something that comes as a direct result and can be attributed to the the amount of storage in your body. So I don't know quite what to do with this, but I think it's intriguing, and it implies important things about Fabry disease that are yet to be understood. We also need to look at the other mechanisms of treatment that are being offered and what they do with this as well. Now, this one has to do with the neutralizing anti-drug antibodies and monitoring of antibody formation. So detailed epitope mapping, and epitope is just a segment of the enzyme. So the enzyme is a very complex, large molecule, and it has to be folded so that it has a certain shape. And if it's in the right shape at the right time, then it does its function. And that, the details of that are way too complicated to cover here, but what this study did was look at which parts of the alpha-galactosidase A enzyme do people make antibodies to. And what they found was that most of the parts, and the parts that are deeply embedded in the folded structure of the enzyme, still get enough exposure to the body to get antibody formation. Almost every portion of the enzyme can have antibodies formed to it. Some of the enzyme alpha-galactosidase A antibodies also cross-react with another enzyme that's important in lysosomal function called NAGA. That may or may not be important, but it is interesting because it means that there are similar structures. And there, at least at one point, was some research done in trying to get to minimize enzyme formation by putting the active part of alpha-galactosidase A onto a different enzyme, and that NAGA would be a good candidate for that, since it clearly has some compatible structural elements. So again, interesting. The other part of this, though, is the neutralizing anti-drug antibodies. And they did not have enough information in this paper to allow us to predict what will result in neutralizing antibody formation. So this one, which was looking at the structure of alpha-galactosidase A and trying to find out what is it about that structure that can lead to neutralizing antibodies. The answer from that study is we still don't know. Then this study, which is also a brand new study, predicting development of anti-drug antibodies. And they didn't look at the structure of the antibody, they looked at the characteristics of the patient. So patients who have nonsense or frameshift mutations are at the highest risk for making high titer antibodies and neutralizing antibodies. They did not test in this for other CRIM negative antibodies, but CRIM, which means cross-reactive, I don't remember what the I is. Anyway, it means you don't make any enzyme at all, that there is no protein made. And I think any CRIM negative mutation is going to place you at high risk to develop antibodies, which means high risk for infusion reactions and high risk for potentially neutralizing antibodies. Higher levels of lyso-Gl3, even if you don't know what your CRIM status or independent of your CRIM status, also predicts higher risk. This study didn't have information on it, but in my practice, we have gone through and looked, and the people with seasonal allergies, the people who have other drugs that they are allergic to or have had reactions to, and the people who have a family history of multiple people with high antibody titers and lots of drug or of infusion reactions are also at high risk. Now, the question then is, what should we do with that information? One is the way we plan the infusions is different. For the patients at highest risk, in my practice, we start them off with a very slow rate of infusion, and we build up in multiple steps the rate of infusion. And that helps people to tolerate the infusions better. And it helps to keep their antibody titers a little bit lower than they would be. The other thing that is relatively new, but that's been done for other lysosomal diseases, is maybe we should do things to prevent antibody formation. And there are pretty well-established protocols for how to do that. Unfortunately, they do require travel to a center that has the ability to do those things, and they require use of immunosuppression for the several infusions while we train your body to accept the alpha-galactosidase A. But if it works as well in Fabry disease as it does in the other disorders where it's been tested, that could make a huge difference for patients in keeping them from developing infusion reactions and in preventing neutralizing antibody formation. So I have recommended that approach twice now. I haven't done it at my center. I don't know if one of the people I recommended it to for Fabry disease, it was recent, and I don't know if they took my recommendation or not. But it is something that I am very interested in, because in Pompe disease, it is a transformational advance to be able to prevent the antibody formation. And I think it will work the same way in Fabry disease. I hope it will, but we'll have to test it.
I've got two related questions here in the comments.
Okay.
It's cross-reactive, immunohistochemical is CRIM.
Okay.
One question was, what would be signs of antibodies besides reaction to ERT? Could increased markers of inflammation be a sign, or is it unrelated?
So increased markers of inflammation have been proposed as a sign, but we don't have enough data to say whether that is a sign or not. there are other things that could cause inflammation. So
Another question, if one appears to tolerate ERT and is not having reactions, can you assume there's no antibody formation, or should one always be tested for antibodies?
So you cannot assume that there is no antibody formation. There are lots of people who have antibody at some level who don't have any infusion reactions. In fact, the majority of males with classical Fabry disease will have, a strong majority of males will have some degree of antibody formation. That level tends to drift down if people aren't having antibody reactions. And there's no evidence that a low level of antibody formation interferes with the treatment effect or leads to problems. So my practice is to monitor antibody levels in all of my patients, but is that really necessary? Bottom line is we don't know. There are people who think it is, there are people who think it isn't. I am an inherently information-seeking guy, so I like to know as much as possible about what's going on, and I don't like to be surprised with bad things. So I look. On the other hand, that does increase cost to some extent, and for my patients, we do other monitoring that involves blood tests, so it's not an added needle poke, but for some people, depending on access to the testing, it may be an added needle poke, and that would be something that's at least a little bit controversial. I don't think there's any harm in having the data, but is there enough benefit to make it essential? Don't know.
I've got another interesting one. Are children more susceptible to have antibody reactions? And if a child has to stop ERT because of reactions, could they try again at some point to see if they didn't have reactions later?
So the answer to that is not completely known. My personal experience is that kids are susceptible to antibodies, are susceptible to infusion reactions, but generally are less susceptible than a new start adult. And the answer, if somebody has an infusion reaction, are there ways to work through that and find a way of giving them the medicine that they need without infusion reactions? The answer is yes, there are ways to do that. Some of them include waiting for a period of time and then reinitiating, and I would say initiating that very gently. We have had a couple of particularly high-risk families where we have started people on a quarter of the normal dose and built up slowly to try to avoid triggering antibody reactions, and with some success, although not enough to say that that's what caused that to succeed, but it worked the way we hoped it would. We have also tried using different combinations of pre-medications, and for people who have established high antibody titers, and particularly those with IgE antibodies, which are a true allergic reaction, there are some added medications, but those medications are very difficult to get approved and almost as expensive as Fabrazyme. But if it's a life-saving treatment, we need to find a way to do it. I have not used the aggressive approach where we use some of these added medications in children at this point, but it would be a consideration.
And then one last question before you move on. When you talk about the improvement and time period over 12 months, This only applies to ERT, correct? Is there any data on the impact of gene therapy or oral medications in comparison?
There is not a lot of information, but there is some information. We know for sure that the chaperone medication does not follow the same course as far as time to effect. It appears to take a little bit longer to get to its optimal effect. But the long-term importance of that is not clear. The same thing is true for gene therapy. Gene therapy, I think, is interesting. At least one of the forms of gene therapy, when you use it, you get an initial high level of enzyme production that comes down, and then you get to a peak or a nadir, which means a bottom out on the enzyme production, and then it slowly comes up so that you get an initial, wow, this is great, it's working awesome, and then it goes down and it looks like it's going to fail, and then it comes back up. And that really was upsetting when it first happened. And now that they've treated a few patients, it's less upsetting because we're going, oh, this is part of the expectation. But it's really important to know that because there are, I think, about 8 different groups doing slightly different versions of gene therapy. It will be interesting to see how many of those have that pattern, and what, if anything, we can do to optimize the effects. Based on other diseases, there may be some gene therapies that will go up and then down and then not come back up. We don't know. So that is, but the gene therapies, you're talking about, if you add all of the clinical trials together, still less than 30 people have been exposed. So we have a lot to learn on that.
So we've got about 7 minutes. If you have some favorite slides coming up you want to pick.
Okay. This one I just very quickly, the assumption has always been that alpha-galactosidase A is a consistently even thing, and that Fabry disease progresses at an even rate, and that if we add enzyme, then it will decrease that. This, again, in the realm of we need to learn more about this disease, somebody measured markers of Fabry disease multiple times per day and found that there is a diurnal variation that's pretty consistent. And they also found that the amount of the biomarkers was independent of how far you were from your last infusion, both of which violate our inherent assumptions. So we have more to learn. This one, AS1C1A, is a gene, and it is upregulated. When it's upregulated, that activates increased pain sensitivity. In an animal model of Fabry disease, they found that that gene is upregulated. If that proves to be true in people, there is a specific blocker for that gene that may be a useful target for treatment of pain related to Fabry disease. This one is, I'm going to skip because you'll hear more about that from other people, but it just shows that we are learning more about the details of heart disease, and that is critically important. And this is the last one I have. There are a couple of papers. This one is by Juan Politai. but there were other papers on it, including one that is in process with Don Laney as the lead author. And the bottom line here is we don't have a ton of data, but the COVID-19 pandemic should not stop you from getting treatment for your Fabry disease. And at least some patients with advanced Fabry disease are in a high-risk group. So we do need to pay attention to preventative efforts to keep people with Fabry disease from getting the disease. That can be done without locking yourself in the house and not stepping outdoors for the next 9 months. But it is something to pay attention to. And I think that's the bottom line on that one. Any other questions or comments?
Oh yeah, we got questions.
Okay.
Here's one. Are there any methods of treatment showing improvements to the heart specifically?
Yes, ERT does improve heart. The chaperone drug also does improve heart. Neither of them is completely good. And then there is at least one group working on a gene therapy that is designed to have particular affinity to the heart so that it will go into heart muscle cells more efficiently than other cells. And the idea is that if you produce the enzyme in your heart and it circulates through your heart, that your heart should be optimally treated. Now, there isn't anything specific that we can say this is clearly the best thing for your heart at this point in things that target the storage or that target the alpha-galactosidase A levels in your body. But we do have evidence that doing this treatment does help your heart. And I think that is really important.
All right, we've got 2 COVID questions. One, how about COVID risk with Fabry lung problems?
So if you have Fabry lung problems, that would place you, at least theoretically, into a higher risk category. So if you get short of breath because of your Fabry disease, that means you have some baseline inflammation in your lungs, and that places you into a higher risk factor, a risk category with COVID-19. What do we do with that? Make sure you wear a mask, make sure you wash your hands, make sure you follow the other standard recommendations for prevention of COVID-19, and be first in line for the immunizations when they become available.
This is from someone. I decided that when COVID was announced that I would be staying home. I switched from Fabrazyme to Galafold. I have not yet been tested to see if it's working for me. What is the best test to see if I'm getting the same treatment as the infusion?
That is a really good question, and the bottom line is we aren't sure. Most people that I have talked to, and what we are doing in Cincinnati, is monitoring the same things that we did. Now, we know that there will be some fluctuation in lyso levels as you transition from one drug to another because the dynamics of the lyso levels and the GL3 levels are not the same between the 2 drugs, but you should not see a major rise in lyso or GL3. You should also pay a lot of attention to the rate of change in GFR and creatinine levels and any of the heart markers that are being monitored closely. in theory, because of the distribution, tissue level distribution, you might see some improvement in pain and GI symptoms because of better tissue penetration with Galafold versus enzyme. However, there's not enough data to know whether that's just a theoretical possible benefit or whether it actually will translate into better outcomes. And we won't know that for probably a long time.
All right, great. Question here. We're going to go a couple minutes over. We've got a slight delay elsewhere, but if you don't mind keeping answering questions, we'll do so.
I will answer questions until you tell me to be quiet.
Okay, it's a deal. In our family, the 2 young adult women have had infusion reactions and the 2 women in their 70s have not had a reaction. Is there any correlation between age and infusion reaction been noted?
Not that's been well studied, although there certainly could be. The only thing that I have noted in my practice is that if I get young people started pre-symptomatically, the rate of severe infusion reactions has been less compared to the adults in their families who start who start with the same mutations. And that's specifically limited to the families that I have with frame shift and nonsense mutations, but earlier starting appears to result in better tolerization. That's not enough data to make a final decision. We need much better data. As far as older patients not having as much, and especially when you're talking about women, the individual variability in women is tremendous. The fact that women get into their 70s and then start puts them on the milder end of the disease. So it could be that that the women who didn't develop just have a milder case of Fabry disease, which would correlate with a lower risk for infusion reactions. But that may or may not be mediated by age.
Here's a good one. Is it recommended to be both on Galafold and ERT for teens?
It's not studied to be on both. There was some discussion when Galafold was first being started into clinical trials of doing combination therapy. I still think that there could be some benefit from that, but the cost of it would make it challenging to get that approved. And bottom line is there's not enough data to even have a rational answer for that, other than that I do think it's an interesting idea that could benefit some patients. Probably not everybody would need that, and we'll have to wait and see if anybody actually goes through the process of doing that kind of a study.
All right. Here's a question. Does our doctor test for enzyme levels and as such if on Galafold? So do you test enzyme on Galafold?
I have just decided, because we haven't had Galafold around for long enough, but I have just put in a request to my team that we add enzyme activity levels to our labs for following up patients on Galafold. And there are some, again, theoretical reasons to do this. There are a few anecdotal cases of people who have either had a better response or a worse response to Galafold than anticipated. And none of them have been published, so that's just rumors at this point. But if you look at the assay that they use to determine amenability, there are some mutations that qualify but barely qualify as amenable. And there are some mutations that are robustly amenable. And we expect that, we don't know if that will correlate completely in people, but we do expect that there will be some amenable mutations that are more amenable than others in people, and that could be clinically important. The enzyme activity response is an easily measurable, available way of starting to address that question. So right now, I don't know if, I don't recommend that routinely to other practices because I don't have any data on which to base that, but I am planning to do that, and we'll be collecting some data over the next few years, I suspect. I also know for sure that there are other large centers that are doing that as well. Do you guys do it, Don?
Yes, we do. But we're trying to figure out when to do biomarkers and when to do enzyme and how often, because right now with COVID, blood in one place at one time, we're like sending people to biomarkers at their close lab cores and then trying to figure out how to do, if lab core will do the enzyme tube and let them send it. So.
Well, and the timing, one of the things that will probably be important in trying to figure that out is the timing in the cycle. So do you need to measure the enzyme level right before they take their dose, or does it not matter? Can it be a random enzyme level? We don't know that. Galafold, under some circumstances at high enough doses, can inhibit alpha-gal enzyme. So if you get the peak level of the Galafold, that might change your enzyme activity level in a way that doesn't correlate with its impact on treatment. Again, that's theoretical discussion, but it is something that we're going to need to work out.
All right, I think it's time to switch to our next speaker, Dr. Al-Khatib. But there is just one question I want you to give a really quick answer to, Rob.
Okay.
I saw a news report of a family in Australia whose son got a one-time genetic replacement treatment infusion to treat Fabry, and he's doing good and doesn't need the biweekly infusions. Is this real or fake news?
So that is in one of the clinical trials, and I can't tell you which one, for gene therapy. And it is, in theory, the way the gene therapy will work. You get an infusion, it's a one-time deal. Although personally, I would currently recommend staying on ERT for at least a year while you let the infusion, let the new cells that make the enzyme set up. And then if it really works the way we hope it does, you will not need infusions after that.
Yeah.
So it is potentially real. All of that is in clinical trial stage right now. None of it is right around the corner for being available on a widespread basis, and we do not have enough data to say one way or the other how it compares with current standard treatments. Lots of caveats there.
Thank you, that's great. So next, thank you, Dr. Hopkin. We all give claps for Dr. Hopkin for answering your questions and doing a great job with some new information that's good to hear. There are more questions, Rob. If you want to hang around and look at chat, you can privately answer some of those. And there was a question, if you would be willing to share your slides if people wanted to see them.
Yeah, you have the copy of the slides.
Mm-hmm.
Do what you want with it. I don't think, well, there's one of them, I think, that I took out of an old deck that's copyrighted. The rest of them, I think, are just my typing up stuff that I pulled from literature.